Hello, it's Mark Chris from Memorial Sloan Kettering, continuing my little series on the initial treatment of patients with lung cancers. In the earlier discussions, we talked about people with metastatic disease. I'd like to switch today to talking about people that are candidates for surgery. The two operant terms here are operable and resectable. Operable means that the patient is medically fit to have an operation and to undergo the extent of surgery needed for a complete resection. And resectable means that in the opinion of the thoracic surgeon who will be performing the surgery, R0 resection is likely to be achieved. Again, these things are not perfect. Experience guides many of our decisions here, and the operative decision is made by a lot of different folks. The surgery decision really needs to be made by a surgeon. And the truth is, the question of resectability comes from the surgeon at your institution in your multidisciplinary tumor board. So what are the stages we're talking about? Looking at the trials of perioperative therapies, the stages looked at are 1B, tumors greater than 4 centimeters, regardless of nodal status, up to 3B, larger primary tumors with N2 nodes. N3 nodes are a different discussion, which we'll hopefully have later on. I think I personally am unbelievably struck by the amount of data and the absolute consistency of data about the use of neoadjuvant therapy in patients that do not have a driver. And that's the first group I'd like to address. It is critical to get sufficient tissue to make sure that there are no drivers present. If you have a driver, particularly EGFR and ALK, it sends you in a different direction for decision making. And also, if you're following package insert, for example, you need to show that the patients are EGFR and ALK negative. To do that, you really should do NGS in 2025. It has to be done on tissue. The data from using blood in these situations are somewhat less than 1 in 5 of the mutations are detected in blood in these earlier stage patients. You must have tissue. Obviously, if you have a positive blood test, that's great. You can use it. If it's negative, though, you must have tissue. So you got to get the tissue, you got to get the answer, and you got to get it quickly. Not an easy situation, rather, we can talk about that. I think the data is very, very clear. In the 9 trials now, 9 randomized trials that have been reported, every single one shows an improvement in disease-free survival by giving neoadjuvant therapy with chemotherapy and a checkpoint inhibitor. I'm struck by the consistency of the trials, by the huge amount of data, and I think that makes this the standard of care today in patients that are both operable and resectable. What about the discussions that go on at our tumor boards about the need for immediate surgery, particularly for sick patients with 1B and 2 disease? Well, I have to say that there is virtually no data for the patient sitting in your office saying that immediate surgery followed by adjuvant therapy is as good or better than the neoadjuvant approach. And frankly, there probably is never going to be a trial that answers that. What happens is when you look at the trials of where people have proposed to do adjuvant therapy, up to a third of the patients or more never get the adjuvant therapy. And it's really a apples and oranges comparison here. And that data just does not exist, and I think is unlikely to exist just by the nature of the problems. For people that have neoadjuvant therapy, there's 2 groups now as well. There are patients that have a major response, particularly a pathologic complete remission or an MPR, and then patients that don't. I think for ones that don't, I think the way forward is clear. You need an alternative therapy. And I personally would urge not giving a component of the neoadjuvant program that was truly not successful, particularly folks that have a lot of remaining disease in the resection specimen. For people with an MPR or a pathologic complete response, the question there comes whether to give perioperative therapy, generally the checkpoint inhibitor after or not. The data here is, again, not going to give you the answer. The trial of nivolumab, not followed by a year of nivolumab after surgery, showed very, very good results and really comparable to those results. The FDA has clearly pointed out that the data supporting the use of the additional year of therapy with the checkpoint inhibitor is not proven. There is toxicity, and in adjuvant situations, the data is not particularly impressive. So, giving that again. I do want to point out the need for consideration of postoperative therapy with radiation if you have N2 disease. When you look at the recurrences noted in the neoadjuvant and adjuvant trials now with better systemic therapy, the recurrences are in the chest. And we must think about improving control in the chest. And frankly, the only modality we have today to do that is radiation. And it's most proven for N2 disease. So I do think it's very, very important for people with N2 disease, get a radiation oncologist in the treatment planning group and see is there a role for radiation in those patients. So to summarize, I think for patients that don't have a driver, operable and resectable, neoadjuvant's the way to go. What you do afterward is difficult. For people with major pathologic response, you could make a good case for not giving any additional therapy. There are FDA-approved regimens to give additional therapy of the same drugs. And for people that clearly progress, you need to think about what other alternatives there are, both local and systemic.